So far in this course, we've been looking at the history of hospice and palliative care and the whole idea of it, its historical antecedents, and then the three main pioneers of the contemporary hospice and palliative care movement, and it's how it develops in Canada. And now we're going to be looking at it more internationally. Now this is a vast topic, so we're just touching on it here, and so part of what starts to happen, and I've called it a movement for a reason. I don't know if everybody would agree with that use of the term, but I use it as someone coming from religious studies, that it has the hallmarks of a movement. It's because it is not just about the practicalities of healthcare. There are ethical, moral components within it, and also how quickly it spreads tells us that there's some kind of gap that it's filling. Something wouldn't be taken up like this so quickly and intuitively by people if it wasn't serving or fulfilling a very important function. Now that said, and we're going to be looking at an article that discusses this, it's been very uneven how it has developed around the world. And so I'm using a map from the article we're going to be reading, which the chief investigator is David Clark. So all roads lead to David Clark. He's the person who wrote the biography of Cicely Saunders. He's written on hospice and palliative care, and very sadly for those of us who work in this area, he retired recently. So there's a huge gap in the field now of particularly somebody who looks at it more from a humanities historical perspective, not just a medical perspective. And so, so we can see with this map, the dark blue is indicating countries where, and continents where there's a better access, the best access to hospice and palliative care. And you can see immediately with the darkest blue being the best, that it's a map also of wealth. And that's, of course, this is what takes us into kind of the ethical and the morals of it. So, and once the WHO gets involved, that's going to be talked about. And so we can see, and it's important to note that even within wealthy countries, there are gaps. And so if we look at the American case, as we know, it's a for-profit system. And so many people don't have access to medical care or paid medical care. So it's patchy even within certain countries. And even within countries like Canada, where there is universal health care, there are regional gaps. And so if I just bring us really close to my home anyway, we didn't get a hospice in North Bay until a few years ago. So there might have been hospice and palliative care in the big cities, but not so much, say, on First Nations or in northern localities. So again, this is a very general view that we're looking at, but there is no doubt that hospice and palliative care is much better developed in these countries that are shown in dark blue. And so this leads us to what Clark refers to on page 805 of the article as the access abyss. So the idea that certain areas of the world have almost no access to hospice and palliative care. And so there are a number of challenges. So in the early days, as we saw, a lot of the development of this movement came about through personal relationships. If we look at Wald and Mount and Saunders, there were all these personal networks of relationship, and then physicians and nurses and writers and psychiatrists who are all part of that network. And so largely in the early days, it was more if somebody became interested in this topic, they would go to St. Christopher's Hospice and then take it back to their country of origin. And so it really was about their own kind of personal drive to get this to happen. That starts to shift when the World Health Organization gets involved, and I'll be talking about that separately. But this happens quite quickly. So as I said, there's clearly a need. Now, in terms of regions, and we look at this map of the world, I think it's important to note that you can see very clearly when I'm discussing the history of hospice, it comes very much out of a Christian Western paradigm. And so I think this can get lost in more sociological examinations of this, or just purely historical examinations of this, that it's not going to work just to put this model onto other cultures because they have their own culture, they have their own religion. And so so it's going to have to be developing in its own way in each society. And so we don't want to get into what I talk about in my other course on health, healing, and religion as biomedical imperialism, where we're just putting our model onto other countries, and it doesn't work anyway. So we're going to see, it's going to be very interesting to see how it develops, how it responds to each individual situation. So just to look at the lightest blue areas, which is the Indian, the South Asian subcontinent, and the African continent. And I would just say that I think, I'm not saying that there isn't need for this, but I think there has to be a recognition of cultural difference. And I know, for instance, in India, it's still very typical when people are in old age that they're kept within the family and they're taken care of by the family. So it may not be that hospices as freestanding institutions are as important in that setting, or it may be that it's only for people who don't have family care. So it's going to look different in that setting, and I think that has to also be recognized. We also have to recognize that if these regions are still battling with diseases, we talked at the very beginning of the course that in countries like Canada, people live to be in old age generally, not always, but generally. And so the issue became about sort of chronic illness and old age often. But what we see in these countries is they're still grappling with things like malaria and polio and these kind of very serious illnesses that are, shorten lifespans. And so when they're deciding in terms of their economics where to put their money, this is a very, very challenging task. If you think if you were the person in a group of people deciding where to put the money, and this is true in any healthcare system. Do you put the money on helping younger people who are ill? Do you use all the money on the elderly? This becomes a really difficult and moral landscape to work with. So we have to recognize also that these regions are dealing with very different healthcare landscapes, and so it might not look the way it looks in the Canadian setting. Clark writes into Comfort Always on page 163, from the 1980s, pioneers of hospice and palliative care worked to promote their goals in many countries, building increasingly on international networks of support and collaboration. Many of these were medical doctors, often working with colleagues from nursing, social work, allied health professions, community activism, and academia. So we can see the way that as the movement goes forward, it's reflecting its beginnings, that it's this collaborative team-based approach. Also, I'm really struck, and I think this is part of medicine generally, that you share information because the goal is the care of the patient. So we really see this collaborative sharing mentality within the movement. And so the first International Congress on the Care of the Terminally Ill was held in Montreal in 1976, and it attracted people from all over the world. So these conferences become very important, and they start to take place in different regions of the world. And so this becomes a really effective way to share information and to create a sense of a kind of international community. And so Balfour Mount describes the first conference. So he says, the first conference was in the fall of 1976. And it featured Cicely and Elizabeth Kubler-Ross, among others. And it was meant to mark the end of our 2-year pilot project. In essence, Cicely told about St. Christopher's and what was done there. Elizabeth talked about her work, and I talked about the pilot project, and that was the first one. We decided that it was sufficiently successful in terms of generating discussion and interest and positive experience that we'd have another. And so this has actually been an ongoing conference into the present. Now, one thing he does note here that I thought was very important is that they wanted it not to be a typical conference. If any of you have gone, they're often just people reading papers and maybe there's some questions. And so there was a recognition that this is healthcare and it's a very specific approach to healthcare. And so Mount included what he called reflections. And he said a lot of these people are, they're working in very stressful situations. And so he wanted to make sure that the conference wasn't just adding to their stress. And then he found that this was the most popular part of the conference. And so I think this is interesting, the idea that the approach should also be in every aspect of hospice and palliative care movement, including conferences, to reflect that care for people. And so these have been ongoing. And then in Europe, we see in 1988, the European Association for Palliative Care was formed in Milan, Italy, by Vittorio Fedafrida, who had been involved in the early discussions around shaping the WHO approaches, which I'll be talking about shortly. And he became the president of the European Association. And so he himself was coming out of pain management, and we see this again and again with some of the earliest adopters of this approach, that they're often coming out of cancer, working with cancer patients and chronic pain. So, and we saw that with Cicely Saunders. So that does seem to be, from the medical angle, where it's all coming from. It starts out with this sort of humanitarian concern with pain management, and then it expands into something larger. So, and again, we see that doctors are often spearheading this, and I think that's not terribly surprising, because they have the kind of cultural capital to be able to do it. So we also start to see an interest in palliative care growing in Eastern Europe in the 1990s. Now, of course, prior to that, it was the Soviet Union. The Eastern Europe was part of the Soviet Union, and so there was a kind of a hard division in the world. So we have to see how global politics also plays into this. And so with the fall of the Iron Curtain, we see much more traveling back and forth and communication back and forth with all the various parts of Europe. In Latin America, the movement was spearheaded by Eduardo Buero, who was born in Argentina in 1955, and he was the son of a cardiologist, and he himself became an MD in 1979. And so again, we see the role of medical doctors here. And so he became involved in medical oncology, so cancer research, and so again, that idea of concern with chronic pain and end of life. And so he goes to Canada to study. And so you can see already by this point in the 1990s and onward, actually he goes there in 1984, from the 80s onward, that St. Christopher's isn't the only node that people would go to. So Canada also becomes one where people are going to study. So he actually goes to study at the National Cancer Institute of Canada at the University of Alberta. And by 1988, he had become the director of the palliative care program in Edmonton, Alberta. And so he became the second professor of palliative medicine in Canada. And so then he takes some of this knowledge back to Latin America. So when we look at Asia, so Korea, Japan, and China, the first evidence of hospice development in that region begins in Korea. And this is through the Calvary Hospice, run by the Catholic Sisters of the Little Company of Mary in 1965. So their hospice actually predates St. Christopher's Hospice. And so we see this, we've already seen this, that Catholic orders were already running hospices prior even to St. Christopher's. And so, so again, Korea, there's actually a large Christian population in Korea. And so those became kind of the beachheads for the movement. In terms of China, again, we see that because it's a communist region, there for a long time, up until the 1970s, it was kind of, there wasn't a lot of communication back and forth, but we're seeing increasingly that China is also part of that larger international community, and there's now an Asia-Pacific Hospice Palliative Care Network that was founded representing 14 countries. In India, it differs by region. India, of course, is a subcontinent, and so so far we find that the most recent study says there are 135 hospices and palliative care services that exist in 16 states, which is not a lot in a region that size. The exception being Kerala. Hospice and palliative care developed very quickly and early in Kerala, and from my own knowledge of Kerala, that's probably because Kerala has had a kind of socialistic view of medicine, and so it's been able, I think, to integrate it more into their healthcare system. And then when we look at Africa, the African Palliative Care Association was founded in 2004. sort of an overarching umbrella group to look across the whole continent. And so one of the main drivers was the chief executive, Faith Mwangi Powell, and she states, and my role is really to take the leadership in APCA in really enhancing our mission statement to promote and support culturally acceptable and affordable palliative care across Africa. So I think this is very important what she's saying here, culturally acceptable. So that idea that I mentioned earlier, that you can't just graft a system that works in a place like the UK or Canada onto another region. So she says, and I think that's really what we are hoping to do by supporting countries which do not have any services to start up, supporting countries which have palliative care to scale up, and so to allow for training and so on. And so a lot of the people working in Africa, there were all of these healthcare crises, particularly HIV/AIDS, that was taking a lot of the money and attention, obviously, because it was such a crisis. And so I think it's really only been more recently that there's been the ability to start to look at these other dimensions of healthcare. I want to conclude by looking at the World Health Organization and the development of an international framework on palliative care, and that, without a doubt, was a watershed moment within the larger movement. And so many of you will know that the World Health Organization is the most important health organization in the world. It's by no means perfect, there's no such thing, but it certainly has a great deal of respect. It has a large budget. It's part of the larger system of the United Nations, and so it works within the framework of understanding the world as an international community. So it may do that imperfectly, but it is, in my experience, it's just widely respected. And certainly Canada, in terms of Canadian healthcare, looks to the World Health Organization. So when I'm teaching on health and healing, I always use their definition of health. It's considered to be the most respected and used definition. And so the World Health Organization, some of you may know, emerges out of the 19th century when there were various symposium looking at things like cholera epidemic. And so we've known this for thousands of years, that epidemics spread through travel, they spread through war, and so on. And so really the whole world is connected, whether they realize it or not. And of course, we've experienced this in our own lifetime recently with COVID. And so some of you may remember, many of us were waiting to hear whether the World Health Organization said that COVID was an epidemic or pandemic. And once they said it was a pandemic, everything began to move in a different direction. And so, the World Health Organization, as I said, emerges from this concern with the way that health is global. And so in terms of palliative care, it first begins to really take this on board in 1990, and it begins with an interest in pain management. And this is important globally because access to opioids differs around the globe, and also laws around narcotics differ around the world. And so it gets involved in this mostly through, again, oncology, through cancer care and doctors involved in cancer care, and then it broadens out. So the first group that gathers in 1990 consisted of oncologists, neurologists, pain management specialists, people working in hospice, and nurses. And again, we see that idea of the team coming together to write up something about pain management. And so arguments for palliative care in the early days were almost always couched in those terms around pain relief. But what starts to happen, and we've already discussed this to some extent in this course, is that what's really happening is kind of a radical change within health, which is the idea that we need to recognize the limits of medicine. So as I talked about at the beginning of the course, part of this is just historical, that medicine was just so successful. I mean, it's absolutely amazing how successful medicine was in terms of dealing with things like epidemics issues like polio, measles, and so on. But what we see by the 50s and 60s is people beginning to realize, even though we can deal with a lot of these things now, there are limits. And so the discussion around quality of life, for instance, and so the idea that palliative care affirms life and regards dying as a normal process. And so that doesn't sound that radical, but it actually is, as we talked about at the beginning of the course. And so we start to see that shift being reflected in the policies of the World Health Organization. And so this early work was endorsed by Cicely Saunders, and we see a broad consensus emerging quite quickly. And again, I think that speaks to the fact that many regions of the world were dealing with the same issues. And certainly we are seeing around the world dealing with the issue of aging populations. So it is not surprising that it caught on so quickly. And I think people around the globe were also recognizing this idea of the limits of medicine, for instance, and the need to include things like family and community. So if we look at the World Health Organization page, I will be linking it on Blackboard. The World Health Organization becomes a kind of clearinghouse for information on palliative care. And so at this point, anybody, anywhere interested in this can just go on the website and look up the information. So instead of it just being you have to go to St. Christopher's Hospice and study, or you have to meet Balfour Mount, it becomes much more kind of accessible to everybody. And there are frameworks being developed and templates that people can look at. And so on the page it says palliative care is a crucial part of integrated, people-centered health services. So we already see that sea change, the idea that palliative care and hospice are becoming part of just healthcare generally. It's not something off to the side and marginalized. Relieving serious health-related suffering, be it physical, psychological, social, or spiritual, is a global ethical responsibility. So that is extremely important. And so in terms of what we're looking at in this course, that spiritual is mentioned directly, but also that it's a global ethical responsibility. And that's very much the kind of impetus of the World Health Organization, that all people have the right to access to healthcare. Thus, whether the cause of suffering is cardiovascular disease, cancer, major organ failure, drug-resistant tuberculosis, severe burns, end-stage chronic illness, acute trauma, extreme birth prematurity, or extreme frailty of old age, palliative care may be needed and has to be available at all levels of care. So we can see it's gone far beyond that idea of just cancer care. So it could come at any point in the life of a person. And so it goes on to say it is estimated that globally only 14% of patients who need palliative care receive it. And so to achieve Sustainable Development Goal 3, working towards universal health coverage, countries have to strengthen palliative care services. So we can see that kind of driving force coming from the World Health Organization, which then also impacts many regions of the world who can then look to the World Health. It's not the only way. I mean, once the person's interested, they'll generally make connections through conferences or meeting, or people are going to other hospices to develop. But with the World Health Organization, we see, and this has been quite recently, 2014, when they fully develop a framework, so very recently, but we see that palliative care hospice has come basically into the purview of universal health care internationally.